for that informative session. Next, we have a 1-hour talk on synchronized non-invasive ventilation of newborn by Professor Corrado Moretti. We have Professor Pradeep Dabetta, Professor of Pediatrics at VMMC and Safdarjung Hospital, Delhi. He is also President-elect 2023 FNNF Delhi. We welcome you, sir, and kindly request you to introduce the speaker.
Good afternoon, everyone. And Professor Corrado Moretti, he doesn't need any introduction regarding if you see his work in synchronized non-invasive ventilation, he's the pioneer actually. And basically from his idea, we have now from non-invasive, from CPAP to NIPPB, and now synchronized NIPPB. There's many papers to his credit, and those are basically the fundamental research of synchronized non-invasive positive pressure ventilation. So without much ado, let us hear from Professor himself.
Good morning. Good morning to all of you. So do you listen to me?
Yeah, you are audible.
And this is the slides. Can you see the full page? Can you see the full page?
No.
No.
We're not able to see your slides.
Ah, yes.
Yes, now we can see.
Just 1 second. Now you can see full page.
Yeah.
Okay, and so thank you very much for your very kind presentation, and also to thank all the organizer of this wonderful meeting for inviting me. And above all, I want to thank Dr. Kumar and Dr. Professor Manoj for inviting me to speak on synchronized non-invasive ventilation. I start with a little piece of history. This is, I think, the first probably paper on intermittent positive pressure ventilation by nasal bronchs. This paper, this was my first paper, and that was published more than 40 years ago. And as you can see in the left, also the time we are looking for synchronization, but because you can see that this is the pressure of the ventilator and this is the thoracic impedance, but we used to do it manually, so trying to set the same parameters of the baby on the ventilator, so the expiratory time and the rate. And at the time we're using these homemade nasal bronchs that are not so dissimilar from the bronchs that we use today. Clearly, the treatment was above all for apnea of prematurity, because as you can understand, at that time was impossible to treat severe RDS due to the fact that we were in pressure-factant area. So it took a long time, in the truth, to see a widespread adoption of this technique. But luckily, in the last year, this technique, non-invasive ventilation, is increasing and increasing, as was demonstrated by this retrospective study, whose goal was to evaluate the change in primary respiratory support in United States infants. As you can see, in this period, the period considered as of 10 years from 2008 to 2018, there was a remarkable and significant increase of the use of non-invasive ventilation, and at the same time, there was a decreased use of mechanical ventilation. This is the high flow nasal cannula, more or less is the same, a little bit a reduction of its use. So, and the authors also reported that thanks to non-invasive ventilation, about 30,000 fewer newborns were ventilated than expected when compared with the 2008 data. Clearly, these changes represent a very significant improvements in neonatal respiratory care. I remind you that there is a direct relationship between the duration of mechanical ventilation and the neurodevelopment of preterm infants. This is a beautiful paper, recent paper, in which were enrolled more than 300 babies, studying the relationship between the NDI and mechanical ventilation. And the conclusion was that there is a strong association, but this is a very impressive phrase, that every additional day of mechanical ventilation is strongly associated with an increased risk of NDI. And moreover, also, a failed extubation has a great risk of complication, of an increased mortality and morbidity. This is another beautiful paper in which were enrolled more than 900 babies, and the authors report that the infant who failed extubation had a significant increase of severe complication, and not only that, but also BPD, intracranial hemorrhage, and so on, length of stay, and so on. So clearly, also to fail an extubation, it has a very high price. For this reason, limiting invasive mechanical ventilation is an important goal in the treatment of preterm infants. But so now the question is, what are the most effective non-invasive ventilation techniques? The answer is given by this beautiful network meta-analysis developed by a colleague from India. The name Vaira, but it's very difficult for me to say the complete name. So this is a very beautiful analysis whose objective was to compare the efficacy of different NIV modes as primary respiratory support. The modes included were fluonasal cannula, nasal CPAP, BiPAP, and NIPPV, but not the synchronized mode. As you can see, many randomized trial 35 were considered with more than 4,000 infants enrolled. The main outcome was the requirement of mechanical ventilation within the first 7 days. So results, NIPPV is the most effective modality to prevent mechanical ventilation respiratory failure, and also the mode with the lowest incidence of BPD and death. Also very interesting is the second network meta-analysis by the same author. In this time, the objective was to compare the efficacy of different NIV modes as post-extubation support. In this case, this is very interesting because more or less all the non-invasive ventilation techniques were considered. Fluonasal cannula, continuous flow, variable flow, nasal CPAP, BiPAP, synchronized and not synchronized ventilation, and also nasal high-frequency oscillatory ventilation. Again, a large number of randomized trials, a large number of infants considered, and the main outcome in this case was the required ventilation within a week. The results are that synchronized nasal ventilation is the most effective mode for preventing extubation failure, and this technique is also associated with a decreased incidence of BPD. So we can really say that NIPPV and above all, if synchronized, are among the most effective NIV techniques, and by all these trials do not appear to be associated with an increased risk of side effects. But when using this technique, we must consider a very important factor, that the upper airways. We have to remember that there is not a direct connection between the ventilator and the lower airways, that is the tracheal tube. And moreover, you have to remind that the upper airways perform functions that for which they must open and close, are all vital functions as breathing, swallowing, speaking, crying, and protection from inhalation. So for this reason, clearly, the upper airways have no structural rigidity, but are made up of muscles connected to rigid supports. The rigid supports are at the top, the base of the skull, at the front, the jaw, at the bottom, the laryngeal cartilages. So clearly, we know that another very important problem is that how the patency of upper airway is controlled during inspiration. Because when the diaphragm contracts, we know that there is an increase of the intraluminal negative pressure with a tendency of the upper airway to collapse. But this collapse is prevented by three simultaneous events. First of all, the opening of the glottis to reduce the resistance. As you can see, this is a picture of top inspiration, and there is a widening of vocal cords. And by contrast, during the expiration, there is the closure that is grunting, as you know. Moreover, the negative pressure stimulates intraluminal pressure receptor, and this determines the reflex activation of the upper airway abductor muscle in order to stiffen and widen the pharynx. And I remind you that the main upper airway abductor muscles are the genioglossus and geniohyoid. These muscles are linked between the hyoid bone and the jaw, and their contraction determines a forward displacement of hyoid bone. You have to consider that the hyoid bone more or less in this position, and the forward displacement determines a widening of the pharynx. So we have to take in mind all these physiological details in non-invasive ventilation. And now let's go on analyzing the interaction of not synchronized ventilation with spontaneous breathing. This is a picture taken by a baby assisted with not synchronized ventilation with a backup rate of 20 breaths per minute. And you can see that most of the mechanical breaths are not synchronized with the infant. Here, the ventilator started at the peak of spontaneous breath, here, the mid expiration, here in the late expiration, and so on. I remind you that the rate of asynchrony is very high. This was demonstrated in several papers. This is one of the last one. This is a well-done, very well-done paper in which the respiratory activity was measured, that was recorded by the electromyogram. And in this study were enrolled very low, 21 very low breathed infants with a very low gestational age. And these authors reported that the rate of asynchrony was about 70%, so extremely high. You have to think that when you set the ventilator on 40 or 60 breaths minutes, as the author of this paper did, this means about 60,000, 80,000 cycles every day, and 70% of them are asynchronous. I suppose that this is very upsetting for the baby. Moreover, there are, as you can see, ventilation is not improved by asynchronous mechanical breath. This is a very old paper by our group. This is a recording of the first attempt trials of flow synchronized ventilation. Here we have the pressure of the ventilator. Here the esophageal pressure that, as you know, is the same as of the intrapleurical pressure, and it shows us the effort of the baby. And this is the tidal volume. You can see that this asynchronous breath perhaps is auto-triggering, perhaps a backup rate. There is not at the same time the effort of the baby. And you can see that from the ventilatory point of view, this breath is practically ineffective. This problem was demonstrated many years later, also by Peter Davis. He studied the effect of non-synchronized nasal ventilation, and he reported that the tidal volume only increases in a significant way when synchronization occurs. And also Peter Davis reported that synchronization occurs only about in 25% of cycles, confirming the previous paper that the rate of asynchrony is extremely high. So the hypothetical beneficial effects due to the non-invasive, not synchronized nasal ventilation are above all due to an improvement in manner pressure, and this means an improvement in FRC. you know that improving an FRC determines a lot of positive effect on respiratory physiology, lower compliance, lower resistance, improve the compliance, decrease the resistance, improve the perfusion of the lung, and so on. Another effect could be that the intermittent inflation of the hypopharynx could stimulate the respiratory drive. And moreover, we can think that superrapid ventilatory inflation enhances tidal ventilation. But I underline, as we have seen in the previous paper, only the synchronous breath are really improved. Moreover, the asynchronous mechanical breath have also some negative effect. First of all, I think this is a phenomenon that we see very frequently, an alteration of the spontaneous respiratory rhythm. You can see here that the ventilator starts at the beginning of the respiratory phase. We have a blow-up here of this image. The ventilator starts exactly in this point. You can see that the baby reacts with a very prolonged and deep expiration. Why? Why? Because probably the lung was overinflated. And this, what we see here is only an Ehrenbreuer inflation reflex. And not only there is a deep expiration that is not a good phenomenon, but there is also a delay following the expiration. The same thing was demonstrated in other papers. I show you this paper by Professor Bancalari. Again, exactly the same phenomenon. This is the esophageal pressure. The ventilator starts during the expiration. You can see here a prolonged exhalation, and here a forced expiration, a positive pressure inside the esophagus. There are some others negative effects of asynchronous breath. There are several papers demonstrating that the asynchrony may also activate laryngeal closure. And it could be the results, because the flow goes in the wrong way. That could be an increase in abdominal distension. All these factors increase clearly the work of breathing, and above all, I think, the discomfort of the patient. I want to underline this last point that is very rarely considered. We know perfectly, there are many papers demonstrating this, that in infants, children, and adults, asynchronous during non-invasive ventilation is an important cause of stress and discomfort. And it is a frequent reason of NIV failure. And we know perfectly that in preterm infants, pain and stress have well-documented adverse neurological impacts as an alteration of the development of brain and cerebellum. So a question that I ask myself very often, but I have not the answer, is asynchronous nasal ventilation a possible cause of stress in premature infants? As I said before, thousands and thousands asynchronous breath every day, I think that could be really a cause of stress, and we should study this problem. But as I said before, I have no answer to this question. But now let's go on to analyze the interaction of synchronized nasal ventilation with spontaneous breathing. Synchronous mechanical breaths have, we will say, have many positive effects on respiratory physiology. This is the recordings of a baby in access control with a flow synchronized ventilation. You can see that the rate of, here we have a long respiratory time, here short, so the rate is the rate of the baby. And you can see that three lines, pressure, flow, and thoracic impedance now are perfectly aligned. The ventilator starts every time the baby starts breathing. So, but why does synchronization has positive effect? The reasons are very simple. Because when the ventilator is triggered, when the pressure rises, at that time the glottis is open. Moreover, the pressure of the ventilator pushes the soft palate against the base of the lung, sealing the oral cavity. This means less leak. Moreover, the upper airway, as we have seen before, are stiffening and widening. Moreover, there is a real collaboration between the baby and the ventilator because As you can see here, there is the negative pressure due to the contraction of the diaphragm, the positive pressure of the ventilator. This means an increase of the transpulmonary pressure. This means less work of breathing. Clearly, the time lag between the start of spontaneous breath and the mechanical breath must be very short. By convention, we say less than 100 milliseconds. Another very important point is that also the thoraco-abdominal asynchrony is reduced. Now, I'm going to show you this problem that is very important in non-invasive ventilation. This is a very old paper, but still relevant. All this data were demonstrated, has been demonstrated in the following years. But this is the previous one, the first paper on this topic, on the thoraco-abdominal motion. Kinziman, the author, placed two strain gauges, one around the chest wall and one around the abdomen. In a perfect situation, the two structures should move in complete synchrony. When the abdomen expands, the rib cage also should expand. But we know that this doesn't happen in very low birth weight infants, but also in infants, that we have a paradoxical breath, especially when the compliance is low. And when the diaphragm contracts, there is an inward collapse of the rib cage. So in order to maintain the same tidal volume, the diaphragm has to increase the shift to improve the work of breathing to compensate the loss of volume. But how can asynchrony be measured? Can be measured in a very single way, by the phase angle, that is the difference in degrees between two waves that move at the same frequency. For example, this is the abdomen, and this is the rib cage. As you can see here, by convention, I have to say one wave is 180 degrees. So in this case, the phase angle is 80 degrees. Clearly, when we have a complete synchrony, the phase angle is 0. When we have a complete asynchrony, the phase angle is 180. And Kinziman studied the phase angle in newborn treated in different conditions. I have to say that the right phase angle, the physiological phase angle in a healthy preterm infant is about 40 degrees, because the diaphragmatic contraction slightly precedes glottal abduction. So 40 degrees is the best, is the goal. As you can see, if Kinziman studied the phase angle in BB treated with CPAP and the tracheal tube, so this is a remarkable increase of the resistance in the worst condition, something that we have never to do. The phase angle is very high, not far from complete asynchrony. Better with nasal CPAP, there is with short nasal prongs. 80 in any case is the double of the normal phase angle, but the phase angle come back to normal value with synchronized nasal ventilation. So the conclusion is that the synchronized nasal ventilation stabilizes the chest and reduces the thoraco-abdominal synchrony. So the physiological advantages of synchronized nasal ventilation are the lowering of resistance, the increase in transpulmonary pressure, decrease of thoraco-abdominal asynchronous, and as we will see in the following slide, this means an improvement in ventilation, improved a decrease of work of breathing, and as we will see also perhaps a stimulation of the respiratory drive. All these things I convinced that it means an increase of comfort for the baby. So coming back to the clinical results, analyzing the improvement on ventilation with synchronized ventilation, I show you again a very old paper, but as I said before, still also this paper is still relevant because this data were all demonstrated in the following years. This is a crossover randomized trial analyzing the physiological effect of synchronized ventilation compared to nasal CPAP after extubation. And we studied 11 very low birth weight infants. So this is the pressure in the circuit. This is esophageal pressure, as I said before, the effort of the baby, and here the tidal volume. Shifting from nasal CPAP to synchronized nasal ventilation, there is a significant lowering of the respiratory rate. The effort is significantly reduced, 1/3 less. And despite the reduction of the respiratory rate, despite the reduction of the effort, there is a significant increase of tidal volume, and also the PCO2 was statistically lower. The same results were obtained many, many years later by the group of Helmut Ramler. This is, he compared directly synchronized nasal ventilation with not synchronized ventilation. I think this is the only paper doing this, this research, comparing directly the two techniques. And the beautiful thing of this paper that the two techniques were applied with the same inner pressure, because 40 breaths were set of not synchronized ventilation, and only 40 breaths were assisted during synchronized ventilation. The baby were with very low gestational age, most of them still in oxygen, it means still in acute phase of the disease. And as you can see, the results were exactly the results we had that I showed you in the previous paper. Significant reduction of the effort, or in other words, of the esophageal pressure, reduction of the respiratory rate, the improvement in ventilation. So improvement in PCO2 removal, and an increase, significant increase in oxygenation. And I want to show you also this paper of some years ago. This is a crossover randomized trial to compare the efficacy of flow synchronized ventilation with an NSCPP and CPAP for the treatment in apnea of prematurity in infant in good condition, but affected by severe episodes. And so the results were that only with flow synchronized, with synchronization, was possible to have a significant reduction of the incidence of this phenomenon, apnea desaturation in bradycardia. And, but there were no differences between NATPV and nasal CPAP. With synchronized nasal ventilation, it was possible to reduce in a significant way all these phenomena. And I want to show this last clinical paper by Manuel Luna, just to show you the efficacy of this technique. He was using in this research, in this trial, flow synchronized ventilation. And he studied a number of baby as elective group. So baby after extubation, elective group, and 92 of these patients with a very low gestational age, in 92% of this baby, the extubation succeeded, was a success. And this is also very important. A large number of baby was failing CPAP failure, again with a low gestational age. They applied for synchronized ventilation as a rescue therapy, and 2/3 of these patients avoided intubation. I think that these are very encouraging data. So what choice about parameters, interface, and trigger for synchronized ventilation? The parameters, I think, is a very simple answer, because more or less are the same parameter that you use during mechanical ventilation, just the peak inspiratory pressure is a little bit higher, 2-4 centimeters. But as you can see, the value of PEEP, inspiratory time, and flow more or less are the same that we use during invasive ventilation. Clearly, don't forget caffeine. About the interface, this is a very, very important point. It's a critical point, because the interface affects pressure transmission to the lung. There are different devices, different shape. This means different resistances. And I underline that currently a widely adopted interface for nasal ventilation is the double inspiratory loop cannula. This is the both tubes. This cannula, both tubes conduct inspiratory flow. This has the same shape as for high flow nasal cannula. But I know that this is loved by everyone, is loved by the infants, because due to the less nasal injuries, loved by the nurses, easy to set up. It favors mother-child bonding, so it's loved by the parents, but this device, it has very often and very high resistance, which could compromise the pressure delivery to the airway. This is something that we have to think about. About the trigger, so the oldest one, I think, pressure sensor, pressure trigger. But you know that especially in very low birth weight infants, the respiratory effort is very weak. So with this device, it's very difficult to try to find the good sensitivity. And so this means that very easily you can have auto-triggering or no triggering. Grasby capsule also is a very good device, but sincerely it's not very reliable over time because the position, to find the right position, the movements, also the abdominal distension are all factors that can alter the function of this device. Moreover, there are some data in this paper that tell us that during fasted breathing, the response of this device is less consistent. This is exactly the opposite that we want. So very good tool, NAVA. The electrical activity of the diaphragm is detected by this catheter. In any case, this is partially invasive because we need this catheter in place for all the time of the treatment. This is also very expensive. So there are some paper, very recent paper, that underline that for a perfect functioning of this device, it's needed a very good neural feedback. And very often the infant, premature infant, a sick infant, the neural feedback is not so good. Our group has developed a flow sensor. That this is something that we use currently in invasive ventilation, but with non-invasive ventilation, there is a big problem of the leaks. But now I'm going to show you our setting. This is a baby treated with slow synchronized nasal ventilation. Here, the flow sensor. The response time is very good, about 65 milliseconds, or this data are published. And we adopted a double loop inspiratory nasal, double inspiratory loop cannula, so the same as iflow-nasal cannula, but we developed a cannula of very low resistance with the diameter of this tube is very high. So we could measure that, we could check that there was a really good pressure transmission of the lungs, to the lungs. And I remind you that in this case, the nasal prongs must fit well because the peak inspiratory pressure and the expiratory pressure is controlled by the ventilator. But I want to spend just a few seconds analyzing this image. Again, you have the pressure ventilation, the flow, thoracic impedance. But look at the flow. And this is a very good thing to have the signal of the flow. You can see that the flow is a very strange shape of the flow because there is the inspiratory phase, but not the expiratory phase. What does it mean? It means that the expiratory flow leaves the airways from the mouth. So it means that this two lungs tube, there is no dot space and no rebreathing because practically never the expiratory flow comes back in the circuit. But this is also obvious because here there is a pressure and the mouth, the pressure is zero. So the suggestion, if you use this technique, never close the mouth of the baby, thinking that so the pressure is transmitted in a better way to the lungs. Moreover, I underline the fact that the flow sensor detects the inspiratory flow, but never the expiratory flow. If you use a normal flow sensor, you will see that after a few breaths, the alarm will beep. You can see here that the flow signal is extremely stable despite the leaks. So we were able to obtain this by a special software that practically reports to the zero line, the flow line after every inspiration. So we resolved, I think, in a very good way, the problem of the leaks, variable leaks. So the take-home messages of my lecture that asynchrony during non-invasive ventilation may have some negative effects on ventilation, the alteration of the rhythm. This is very frequent, and probably also the patient comfort, and also on the quality of sleep. But we have no data about this. I again underline that this is something that should be studied. By contrast, the synchronization integrates with the complex physiology of the upper ways, reducing walk of breathing and improving ventilation and comfort. Synchronized nasal ventilation is a technique very well studied, and there are Many papers demonstrated that it's better than an IPPV and nasal CPAP, also than BiPAP, in reducing the need for intubation as primary support in RDS, in improving the success rate of extubation, and in reducing the incidence of apnea desaturation in bradycardias, as I showed you before. So I conclude, underline that flow synchronized nasal ventilation performed with a low resistant double loop inspiratory canal can be used successfully. And so the good thing is that we were able to combine the physiological advantages of synchronization with the same comfort and easy use of this interface, of the double inspiratory loop canal. Thank you very much.
Thank you, Professor Moretti. You made us to understand what is the anatomy involved, what is the physiology behind the synchronized NIPPV, also the clinical implications that we usually we require in preterm, that they should not get mechanical ventilation and the rate of BPD should become, there should not be any more work of breathing which led them to mechanical ventilation and intubation. So synchronized NIPPV is one of the best mode. We started from CPAP, non-invasive ventilation, now synchronized non-invasive positive pressure ventilation is the norm to prevent mechanical ventilation. So thank you very much. Any question from audience?
Okay. Yes, I want to underline that no one today would use not synchronized ventilation in the invasive mechanical ventilation. I think that we are going exactly toward the same goal. That I think that in the future, every child, every newborn will be ventilated with synchronized nasal ventilation, because the path is exactly the same as what happened many years ago. But who would treat with not synchronized ventilation intubated today? No one. Everybody would say that there's a crazy thing. I know that with non-invasive ventilation, there is a less direct barotrauma, but more or less the problem are exactly the same. We have to consider this.
Okay. So any question from the audience?
Sir, regarding my question is like concerning regarding CO2 levels, sir. If it is synchronized NIV, there is a chance of any hypocarbia and any neurodevelopmental issues. And one more question is, kindly share your experience regarding the volume compensation, how much leak compensation is happening, and how your ventilators are compensating, how much percentage of leak compensation is happening.
No, so the first, the hypocarbia, I heard well. The first question.
About CO2 washout. His concern is that if we keep synchronized NIPPV, then there will be more CO2 washout.
So no, there is any problem about CO2 removal because so it's the baby who determines his own respiratory rate. And so we never had problems. So we had an improvement in removal of CO2, but always at physiological levels. And about the leak compensation, you know, when we use that, in our device is not needed because yes, there are the leaks, but when you set the flow of 8 to 10 liters, so the flow is much higher than needed. So there are variable leaks, but usually the pressure that we set, that is in the range of 15-25, is reached. I don't know if the leak compensation is so useful, because it means that to increase abruptly the flow, and so this also have bad effects. So this is in our device is not a problem. Currently, we like better to have a constant flow, and it can happen that sometimes one or few hacks have a little bit lower pressure, but this is not so important at the end.
Thank you, Professor. Anyone, any question?
Hello, it's a very good talk. My question is regarding the interface. On a dragger, we can use a CPAP interface to give CPAP through the ventilator. For what sort of interface? Is it the same interface you use for SIPPV? For synchronized non-invasive ventilation. What sort of interface are available, or can we use the same CPAP interface?
So the interface that we use is usually nasal prong. I have not experience with a nasal mask. This is something that we are going to try, but most of all our trials were done with normal short binasal prongs. In the last period, we developed the double respiratory loop cannula, and we, thanks to the fact that we can see the flow, we saw that there was never rebreathing. So the two lungs tubes were not a problem for rebreathing at that space, because the expiratory flow was, as I said before, leaves always the areas from the mouth, so there is no rebreathing. So now we are using more and more these cannulas, because, as you know, the parents and nurses, everyone is much happy with this more comfortable and easy to set prongs. This is something rather new. And underline that we develop a special flow cannula, special cannula for this with very large resistance, so 2 large tubes, but in any case comfortable.
Good afternoon, sir.
One more question.
Yes, sir.
One more question is coming.
Thank you very much for the excellent talk. I just want to know whether this is one step ahead of CPAP. So is there any head-on, because the indications after CPAP failure for mechanical ventilation is same. So the mechanical ventilation compared to synchronized non-invasive intermittent positive pressure ventilation, is it a head-on any trials which you have done, sir?
Sorry, could you, because I have an echo, and so I didn't understand well, sincerely. If you try to speak a little bit slower, or if the chairman can tell me your question.
Sir, indication for mechanical ventilation after a CPAP failure is the same. So
Yes.
we just, yes, sir. So we just go ahead with synchronized non-invasive intermittent positive pressure ventilation. And is there a trials which compare synchronized non-invasive intermittent positive pressure ventilation with outcomes of intermittent mandatory ventilation, which is, we all know it is it's an invasive one, but there are little tiny premise where they have little bit of flow only, or the volume which may not be the impedance, thoracic impedance or the flow, they may not produce adequate enough to get the trigger of through synchronized non-invasive positive pressure ventilation.
Yes, I'm sorry, but I didn't understand.
Basically, our question.
There is an echo that amplify everything. I don't know why.
Basically, our question is, after CPAP failure, is there any comparison between synchronized NIPPV and invasive mechanical ventilation about the outcome?
So no. Yeah. So I showed you that before the paper of Luna that it was possible to avoid to 60% of his patient the invasive mechanical ventilation is shifting from nasal CPAP. The baby was failing, and he used the synchronized ventilation as rescue therapy. And in 2/3 of these babies, mechanical ventilation could be avoided. And there are data from the meta-analysis of IRA, and also there are two previous meta-analysis to Cochrane's. All of them reported that there is really the hope that the BPD, the rate of BPD decreases with this technique. But I think this is normal because this ventilation respects the physiology of the baby, and these things doesn't happen with not synchronized. What I said before, who would use not synchronized invasive ventilation today? No one. But so the problem is exactly the same.
Sir, is there a trial where you had compared flow sensor versus thoracic impedance, which we are using head-on trials for synchronized non-invasive positive pressure ventilation?
Sorry.
Flow sensor versus thoracic impedance.
We use the flow sensor, but what you asked me, sorry, I'm really sorry.
Okay.
Can you, the chairman, can you, I listen better to the chairman, not from your, the chairman, if he could repeat the question.
Sir, thoracic impedance, you are using a synchronized non-invasive positive pressure ventilation. You had showed two of your studies where you had used flow sensor
Yes.
and thoracic impedance, the other one. So, is there any trials which shows any difference between flow sensor versus thoracic impedance?
No,
As a trigger.
yes, understood. No, we never did the comparison. We know that the thoracic impedance, you know that the Grasby capsules is many years that is on the market, but it's well known that is not very reliable. It's good for research, but because you can stay, but you have to stay close to this device because if you use for a long time, that could be a problem, and it's not very reliable. So this is the reason why. Otherwise, it's so simple device that everyone, all the ventilators could have this device currently. But why all we try to find another solution with flow sensor, and there is the NAVA. So there are attempts to increase the efficacy of the devices because the Grasby capsule is good, but not so good.
Sir, and volume guarantee with synchronized non-invasive positive pressure ventilation, volume guarantee added on with your synchronized one, like HFOV we are doing with nasal HFOV with volume guarantee. So something like that. Is there a trials?
The problem in the non-invasive ventilation is that we never know the volume. Is because the expiratory volume, there are leaks, from especially during the expiratory phase, leaks from the mouth. As you know that the tidal volume is measured during the expiratory phase. So it's currently it's impossible to know the tidal volume. Now, I don't know, in the future, now there are new tools to see the expansion of the lungs by electrical tomography or something like that. Perhaps one day will be possible to know the volume also during non-invasive ventilation. But currently we don't have this chance. But so we have seen that in any case, due to the leaks, the direct barotrauma is less. In any case, there is the possible for an overflow to leaks to leave the airways from the mouth. And so we never reported an higher incidence of air leaks with this technique. This was underlined in many papers. Also, if we don't know exactly the expiratory tidal volume, this I think it's a very difficult challenge for the future, and that I suppose that will be resolved by electrical tomography or something like that. But in any case, if you use the parameters in the range from 10, 15 to 25 centimeters of water, we never had problems with air leaks.
Thank you so much, sir.
So sorry for my difficulties.
Sorry for the last language.
It's the microphone, I think, your microphone. Okay.
Okay, thank you, Professor Moretti. It was a very nice experience hearing from you about synchronized NIPPP, which is your passion itself. Okay, thank you so much.
Thank you very much.
Thank you, Professor Moretti and Professor Pradeep.